Hi everyone, welcome to another episode of Excela Health Virtual Mall Walkers, and happy Heart Month. Throughout this month, we will be sharing with you a wealth of heart healthy tips and resources on how you can keep your heart health a priority. Walking is also a great way to support your heart health, which brings us to today's walking journey activity. Are you ready? Let's get walking. Today, we're headed to the Big Apple, New York City. We're going to start our virtual walk on Broadway, making our way over to the Statue of Liberty, then strolling over to Central Park. Total miles for today's walk equal 13.2, which is about 26,400 steps, more than double the recommended daily step count goal from the American Heart Association. Remember, if you can't achieve the daily step count goal, do what you can. The important reminder is to keep moving and keep active. Now that we've worked up our appetites from our walk, let's check in with Dawn DeVoli for another segment of What's in Your Pantry.
Hi everyone, and welcome back to another episode of What's in Your Pantry. Today's walking tour takes us through New York City, also known as the Big Apple, and our feature recipe happens to be created right here in New York City. We're going to be making Waldorf salad. Now, the Waldorf salad was created at the Waldorf Astoria Hotel right on Park Avenue in 1896. But our version that we're going to be making today through the demonstration is, of course, a healthier version. But before we start with the preparation of our salad, let's take a look at the ingredients. So, the ingredients for our healthier Waldorf salad include Gala apples, red and green grapes, celery, chopped walnuts, plain Greek yogurt, sugar, lemon juice, and salt and pepper to taste. Okay, so let's start off with the dressing for our healthier Waldorf salad. So instead of using the fat-laden mayonnaise that a typical Waldorf salad would use, we're going to be using a healthier, higher protein, lower fat, plain Greek yogurt. And to the Greek yogurt, we're just going to add our fresh lemon juice and our sugar. And we're just going to give this a stir. Okay. If you wanted to make this diabetic friendly, you could use a sugar substitute, such as stevia. You might want to experiment with how much you want to use to get the right sweetness. Okay, so this dressing is nice and mixed up. So let's take a look now at the fruit part of our healthier Waldorf salad. So of course we're using apples, right? We're using Gala apples. If you don't have Gala apples, any kind will do, but the Gala apples are mild in flavor and they have a really nice crunch to them. So I've taken the apples and the red and the green grapes and I've cut them into bite-sized pieces. To this we're going to add our chopped celery. And then we're going to be adding our fiber-rich, healthy fat chopped walnuts. And then we're just going to give this a stir. All right, so you can see how colorful it is. And then we're going to add the dressing. Okay, so this recipe can be a side dish. If you're going to serve it as a side dish, the calories come in at less than 150 calories per serving. But if you wanted to make this a main dish, you could go ahead and add some grilled chicken or some grilled turkey to the salad. So now we're just mixing up the fruit with the dressing. You want to make sure that all the pieces get coated with the dressing like this. Okay, so you can see how colorful this salad is. This healthier version of the Waldorf salad is full of antioxidants, vitamin C, fiber, all good things that help support our heart health. So, the healthy habit tip of the day for today's recipe is when we think about salads, right, we oftentimes think of just using vegetables in our salad, but don't forget about using fruit like we did today. Fruit also contains the healthy antioxidants, the healthy fiber that we're looking for, and they make wonderfully tasty salads. So I hope you'll give this a try. I'm actually going to serve this as a side dish tonight. One more look. There you have it. I want to thank you again, as always, for joining me. I hope that you will stay tuned. So until next time, stay healthy, keep walking, and we'll see you later. Bye-bye.
Welcome back, Mall Walkers. We hope you enjoyed today's cooking demonstration and our healthy habits tip of the day. Don't forget to check your email inbox for today's featured recipes, along with additional heart-healthy resources. Before we wrap up for today, we have a special featured physician presentation to share with you. Dr. Basil Sayegh from Excela Health Electrophysiology shares the concept of electrophysiology, irregular heartbeat issues, and how Excela Health has the capabilities to treat these issues. Stay tuned for his presentation. Until next time, stay safe and stay healthy. We'll see you soon, Mall Walkers.
In Touch is a public affairs presentation of Broadcast Communications, Inc.
I'm Eric O'Brien, keeping you in touch with the community. Today on In Touch, our friends at Excela Health offer many healthcare services to the area, and today we are going to talk about their cardiac electrophysiology service. If you've ever experienced irregular heartbeat issues, that would be the department where you would go to see about that. So joining me today is Dr. Basil Sayegh from Excela's Cardiac Electrophysiology Department. Dr. Sayegh, welcome to In Touch.
Hi, Eric. Thanks for having me.
You just recently joined Excela. I was doing a little research on you. What made you decide to go to Excela Health?
Yeah, I actually have been in the area for a few years now. I finished my training in UPMC, and before that I was in Allegheny General, so I've been around for a while. What attracted me to Excela Health the most is that the leadership team, along with the cardiology team overall, have a vision for cardiology to be a full-service division, where we could offer our patients everything within cardiology and within electrophysiology as well, without the need to ever have them travel to the city or any other place outside Excela Health for any cardiac matter. So I wanted to be a part of this culture. It's exciting to feel like you are making a difference in the community. Kind
of making a headway, out in what we used to consider the country, but is becoming pretty urban itself out there in Westmoreland. So very, very good move for you, I'm sure.
Correct. I agree 100%.
What is cardiac electrophysiology? It sounds like a mouthful to say, but what is it? What is it the study of, essentially?
It is a mouthful, actually. We tend to use the word EP as a shortcut for electrophysiology because of how often we use it. But electrophysiology is a subspecialty within cardiology that studies the electrical system of the heart and deals with different heart rhythm problems and treat them with medications or minimally invasive procedures such as pacemakers, defibrillators, ablations, and Watchman procedure. A cardiac EP or electrophysiology is a cardiologist who basically, after finishing cardiology training, completes an extra 2 years of training beyond that in order to be board certified for cardiac electrophysiology. It basically focuses on the caring for patients with So cardiology overall focuses on the caring for patients with disease of the heart and blood vessels, including heart attack, valve disease, and some arrhythmias. But then when it becomes specialized within rhythm problems and electrical problems of the heart, this is where electrophysiology specialization comes into the picture.
I see. So it's a little more specialized in terms of cardiology. And do you have a special interest in the field yourself? Is there any particular area you work on more than others, or?
I actually do on all aspects of electrophysiology. I work on all of them. But if I have to choose a field, I would say atrial fibrillation is what attracts me the most, and also the field of left atrial appendage closure, which is called Watchman device to get patients with atrial fibrillation off blood thinners.
Okay. And we are going to talk about that. So let's get into that area of the whole thing, atrial fibrillation, or they call it AFib sometimes. It's basically an irregular rhythm, which could be a number of things, but AFib is kind of the most well-known or most talked about. What is it exactly? What happens when somebody has AFib?
Yeah, so you're correct. AFib is very common rhythm. Right now, there is 6 million people who have it, and by 2030, we're expecting this number to double, basically. So it's a very big health issue that a lot of people deal with. But as you mentioned, it's an irregular and often rapid heartbeat that basically can increase the risk of strokes, heart failure, and other heart-related complications. Basically, the heart have two upper chambers, which we call the atria, and two lower chambers, which we call the ventricles, and they usually beat in synchrony. When the two upper chambers beat chaotically and irregularly out of coordination with the lower chambers, this is basically what's AFib. And we call it atrial fibrillation or AFib because the upper chamber of the heart is called the atrium. And this chaotic movement we call fibrillation, and this is where the name comes from, basically. And usually patients experience different kind of symptoms. So you would see some patients who are experiencing palpitations, or they might say, I feel fluttering in my chest. Other patients would feel short of breath, would feel weak. There is a really whole wide range of symptoms that patients can experience. Some patients even say that I just don't feel right, doctor. And a lot of the times we end up finding that they are an atrial fibrillation. Those episodes can come and go, and sometimes you can have atrial fibrillation that doesn't go away and require treatment. Atrial fibrillation itself is... Sorry, go ahead.
I was going to ask you if people felt it all the time or just sometimes, or if it was something that was easily caught, so to speak.
That's a very good question, because we see... Again, like a whole wide range of different symptoms. So I would see patients who are continuously in atrial fibrillation and they don't feel anything. I would see patients who would be just visiting their primary care physician for a routine visit, and on an EKG, they know their primary care physicians notice that they're now in AFib and they had no idea. And at the same time, I have patients that are very sensitive to atrial fibrillation who would have a lot of palpitations and low energy and fatigue and shortness of breath, that it really affects their quality of life.
The sooner you get it checked out, the better off you are.
Absolutely. So basically, the earlier you start treating atrial fibrillation, the better the outcome is. The reason is when we see patients who've been in atrial fibrillation for years and years, it's very hard to get them out of the atrial fibrillation rhythm. So I would recommend that if the patient is newly diagnosed with atrial fibrillation, that he would seek medical attention and see us in electrophysiology, where we can have some different options to discuss at that point.
Now, is there a cure for AFib, or is it just one of these things that have to be treated throughout a person's life?
Yeah, that's a very good question. So a lot of the things that I discuss with my patients in clinic is that what is the expectation of the AFib treatment or the atrial fibrillation treatment? The reason is that it's more like a chronic condition of the heart overall. It's like the osteoarthritis of the heart. So basically, there is no one medication or one procedure that will just take away the AFib forever. It's more like a continuous relationship between me and my patient, where at each point of time we discuss different treatment options. So sometimes we can treat the atrial fibrillation with medications that will basically make it quiet down or take the burden or the amount of AFib that the patient is having to a much less degree where it doesn't even bother him. And sometimes there are procedures, which is the AFib ablation procedure, that's been showing very satisfying results and a very good safety profile, especially with the recent advancement in technology in the past decade or so. So basically, it's all driven by the patient's symptoms. And our main focus usually with atrial fibrillation is preventing complications from the rhythm itself. But more importantly is to make the patient feels better and improving his quality of life that could be heavily affected by the atrial fibrillation.
Now, you said this earlier, but one of the usual prescriptions is for a blood thinner. What does the blood thinner do essentially, and how does it help in the process? And then what if somebody can't take a blood thinner? There are some people who just can't, right?
Yeah. So if you ask me what's the most important thing in atrial fibrillation, it's basically preventing a stroke. But why does the atrial fibrillation itself can cause a stroke? The reason is, as I mentioned earlier, this upper chamber of the heart is not beating right, and it's just moving chaotically. So sometimes the blood kind of stays there without enough motion to the point that it would create a clot. And that happens in a very small piece of this upper chamber we call the appendage. So when the clot forms there because of this abnormal movement, it could travel outside the heart into the circulation, and it could cause a stroke. That's why when we see atrial fibrillation patients, we start blood thinner. And the main reason is to protect our patients from having a stroke with the presence of atrial fibrillation. If the patient is unable to take blood thinner, like you asked me earlier, and that's a very common scenario as well, because there are a lot of different scenarios where the patient is taking a blood thinner and he has issues with bleeding and a lot of different problems that could happen related to blood thinners. And at that point, we discuss the Watchman procedure or left atrial appendage closure procedure. And this is basically a procedure that was started a few years ago. And the idea is to place a filter in that area of the heart where the clots are coming from to prevent the clots from traveling outside that area and preventing them from causing a stroke. And usually we can get the patients off the blood thinner after we do this procedure.
Okay. Are 100% of the people who have strokes, have they had AFib, or is that just one of the various things that can lead to a stroke?
No, it's actually one of the various things that could lead for a stroke. However, it's one of the leading factors. So whenever our colleagues from neurology see patients with strokes, they do a complete workup. And one of the workup is to make sure that the patient is not having episodes of atrial fibrillation that we're not aware of. So a lot of patients with strokes end up getting a monitor at home that stays on for a couple of weeks to keep a close eye on their heart rhythm. And sometimes we even use other devices that could stay for longer, just to keep a very close eye on the heart rhythm and make sure there is no atrial fibrillation that we're missing as a cause for the stroke.
Okay, very good. You're listening to In Touch. I'm Eric O'Brien. We're here with Dr. Basil Sayegh from Excela's Cardiac Electrophysiology Department, and we're talking about AFib and heart irregularities, really, and the services that they offer to correct or at least help correct some of those problems. What are some of the other causes of heart irregularities, heartbeat irregularities, that is?
Yeah, there are different abnormal rhythms that could happen in the heart. So, as I mentioned, the atrial fibrillation is a irregular, mostly rapid heartbeat. There is other fast heart rhythms. We call them supraventricular tachycardia or ventricular tachycardia. All of these are abnormal rhythms of the heart that we can take care of either with medications or with an ablation procedures. And those usually happen in the context of heart failure, weak heart muscles, or previous heart attacks. And the other abnormal rhythms are the slow heart rhythms. So we see a lot of patients with slow heart rates that are having symptoms such as feeling lightheaded or dizzy or feeling fatigued or low energy, and in some occasions even passing out because of the slow heart rate. And for these scenarios, we use a pacemaker, which basically controls the heart rate and makes sure that the heart rate doesn't drop too slow. And in certain occasions as well, there is the patients who have heart failure with weak heart muscles and have a risk of having a sudden cardiac death. And for these patients, we put devices called defibrillator, and these are devices basically that keep a close eye on the heart rhythm. So whenever the heart goes into a dangerous rhythm or goes into a cardiac arrest, it delivers a shock to get the heart back to beating again.
So that's kind of like a pacemaker in a sense. It is in that person?
Correct. So basically the pacemaker and the defibrillator, the defibrillator has an extra function, which is basically delivering a shock to revive the heart, basically, while the pacemaker only makes sure that the heart rate doesn't drop too low.
Okay. So, doctor, how often do people with pacemakers or the defibrillator device that you mentioned, how often do they have to be looked at or replaced or repaired or?
Yeah, that's a good question. So basically, we have in Excela Health a very robust device clinic, and our patients luckily are able to send their information from the pacemaker and the defibrillator remotely without even having to come to the clinic, which has been very helpful during this pandemic, actually.
Sure.
So we get information from these devices while patients are sitting home. And at the same time, if they had any issues or symptoms or they had any concern, they can always also send us a remote transmission from where they are. And basically, we keep an eye on their battery life. And the battery life varies a lot, depends on how much the device is being used and what's the function of the device. But usually it takes years, more than 5 years, sometimes 10 years, in order for the device to need to be changed. Other things that we keep an eye on, we make sure that all the parameters on the device are stable and it's functioning well. And that's something that we also do routinely. Our nurses have a lot of experience, years of experience actually, in managing devices, and we can manage all the different kinds of devices and keep a routine monitoring of the function of these devices.
Now, it sounds like they're a lot more technologically advanced than they used to be, but there used to be a time where you couldn't be in a room with a microwave oven if you had one of these devices and it was nuking a potato, for instance. It would kind of set it off. Is that still not a good thing to do, or what?
Yeah, you're absolutely right, Eric. I mean, the technology advancement has been very robust in the past years, and I get this question a lot from my patients as well. There is really no restrictions anymore with these devices, and you can even get an MRI now with these devices. So I think we made a long way from the past few years where it put a lot of inconvenience on our patients, where now they can just go on and do all the activities they need to do with no limitations.
Good to know, because I think cell phones were another factor in that too for a while, and those are here to stay. So you had to kind of work together, didn't you?
Correct. Yeah. No. Absolutely. I mean, the device industry put a lot of time and effort into putting new technology where the restrictions are almost down to nothing regarding the devices.
Sure. Now, are pacemakers and ablation procedures, are they kind of a last resort, or are they, just in general determined by the severity of the situation?
Yeah, no, Eric. I mean, the ablation procedures are definitely not a last resort. If
Okay.
anything, because of the advancement in technology in the past years, and because of the need for these procedures, because the medications for arrhythmias are not, as I mentioned, completely curative. And they tend to have relatively more side effects compared to other cardiac medications. So there was a significant need for a procedure that could potentially get the patients off their medications.
Okay.
So I wouldn't say the ablation is a last resort. I would say the ablation should be discussed as a first-line therapy for most of these arrhythmias right now.
Okay.
The patient might decide to go down the medication route, and that's most of the times it's a discussion between us and the patients, and it's a more like a shared decision-making kind of thing. But the ablation procedure is offered as a first-line therapy for a lot of these arrhythmias these days because of the technology advancement and because of the improvement safety profile. So when I see a patient who had an ablation procedure 10 years ago or 15 years ago, he would tell me that the ablation procedure lasted for 8-9 hours and he had to stay in the hospital for a few days after. These days, we're able to perform complex ablation procedure in less than a couple of hours, and the patient is discharged home the same day in a lot of occasions.
Oh gosh, so that's again, advancements have come a long way. So
yeah, this field is changing fast because of the amount of improvement in technology.
Dr. Saeg, earlier in the discussion, you talked about the Watchman procedure. What is it exactly? It sounds new and exciting, really.
It is new, actually, and it's very exciting because it allows us to have some other options for our patients who need to be on a blood thinners but cannot take it for different reasons. It's basically a minimally invasive one-time procedure to get patients off blood thinner. It's done with one catheter that goes through the groin, no surgical incisions, no sutures, nothing like that. It takes about 45 minutes to be performed. Basically what we do, we put the device in that area of the heart that I mentioned called the appendage, where the clots tends to come from. And this device functions as a filter to prevent these clots from going anywhere into the circulation and preventing them from causing any strokes. It's a very exciting procedure because of the improvement in quality of life that it provides for our patients when they get off blood thinners that they've been on for years. And also for the protection that we provide for our patients from stroke, which could be debilitating and have a significant impact on the quality of life of our patients and their families. I really enjoy seeing my patients' reactions the moment I tell them that they can now stop taking the blood thinners and they don't need to be on it anymore without worrying about a stroke, because a lot of our patients really struggle with their blood thinners and it just affects their quality of life on a daily basis.
I would imagine being on a blood thinner long term could be just as detrimental as anything else, right?
Correct, yeah. I mean, it just adds a lot of layers of complexity to their lives on a daily basis. And it's just every time I talk to my patients about their blood thinners problem, I just learn more and more about the daily struggle that they have with their blood thinners.
So would it just be a patient on blood thinners, or who would you have consider doing this procedure?
That's a good question. It's actually an expanding field right now, and there is a lot of different studies and trials to decide which patients would benefit from this procedure. Currently, in the U.S., the patients that we offer these procedures for are a lot of patients actually with atrial fibrillation. So any patient who had any history of bleeding in the past, because, common sense, these patients cannot be on a blood thinner because they will most likely bleed again. And this bleeding could be brain bleeding, could be GI bleeding, blood in the stools that they might have noticed, any spontaneous bleeding, excessive bruising, Issues with taking the blood thinners. For instance, some blood thinners are cost prohibitive for some patients, and sometimes there is different side effects for blood thinners other than bleeding. For instance, there are patients who require to be on another medications called antiplatelet after they have a heart cath and stents, and they have to take it in addition to the blood thinner, which adds to the risk to the bleeding risk. There is a lot of patients who have issues with keeping balance or weakness, and they have recurrent falls. And we really worry about these patients when they fall and they're on a blood thinner, obviously. And then there are a lot of patients who have severe kidney problems where the blood thinners levels are too high in their system and puts them at risk as well. In addition, there are patients who have occupation that puts them at high bleeding risk. So for these patients, it's also something that we could offer. Other patients have issues like cancer or tumor-associated bleeding or any type of bleeding that they would require to be off their blood thinners, and the Watchman procedure would be a good procedure for them or alternative for blood thinner to protect them from stroke.
Well, let's talk about what Excela has in the technology department as far as electrophysiology goes. What kind of equipment do you have, and how quickly can you determine what people need out there?
Yeah. So as part of this vision that I mentioned to you at the beginning of this interview, we actually provide a full EP service in Excela Health. So we're able to perform all types of EP procedures in a very well-equipped and advanced electrophysiology lab. So we're able to perform pacemakers, defibrillators, ablations, Watchman procedures, and all the EP or electrophysiology diagnostic testing involved. And as I mentioned, we have a very robust device clinic. Our patients are able to send their information remotely and directly to the clinic without the need to come to the office. Our staff and nurses have years of experience in dealing with any device issue. And we are now also able to perform the Watchman procedure to get patients, a lot of our AFib or atrial fibrillation patients off their blood thinners. So I would say it's a full service. There is nothing that we cannot provide for our patients, and we're very excited about that.
And where are the offices located? What Excela centers, or are they throughout the county?
So basically, we have offices in multiple locations. We have offices in Greensburg, in Irwin, and Mount Pleasant. We also have offices in Latrobe.
Okay, very good. And how do they contact you?
So basically, they can use our main phone number for our EP clinic or electrophysiology clinic. It's 724-689-1355. And usually our EP clinic try to accommodate our patients to be seen as soon as possible in the best location that serves them the best.
All right, Dr. Basil Sayegh from Excela's Cardiac Electrophysiology Department, thank you for being with us today.
Thank you very much for having me, Eric.